Good morning to you all. And as I promised that I will be talking to certain topics on which are important from the prospective view of UPSC forthcoming examination, and not only in the UPSC examination. And this can be benefited. The chapter which I am just going to explain to you will be beneficial for the UPSC aspirant, as well as the person who are the aspirant, or who are preparing for NEET PG, and those who are preparing for the NEET super specialty postdoctoral examination also, and even for the PGTs of obstetrics and gynecology. So firstly, I will be starting with the as I promised to you all, that I will be starting from germ cell tumor of the ovary. And though it is a very small topic, but frequently the questions are basically the questions do form, and it do comes in the it do appears. I have seen at least twice thrice in the UPSC exam also, and even I have seen in the PGT also, PGT various universities I have seen, and in the NEET PG also, in the FMGE also. So it is a very vital and it is a very important chapter, and you should have a thorough understanding and thorough concept clear about this chapter, and particularly of germ cell tumor of the ovary. Rest the variants I am not going to discuss in a nutshell, because this video will be around 15 to 20 minutes, and then I will be discussing about sarcoidosis, which I will be dealing with the later half of the evening, because today is now is in the now I'm talking in the early morning. So now if we discuss about the germ cell tumor of the ovary, firstly there are different types of tumors in the ovary which are formed. Now firstly in the non-epithelial ovarian tumor. Now basically you must know that in the case of the non-epithelial ovarian tumor, germ cell tumor are the most important, and they are the first in the list, followed by the sex called stromal tumor, and then metastasis, and then the other tumors. The other tumors may be sarcomas, and it may be uh, uh, it may be neuroendocrine tumor also, where you can get other markers positive, like the neuroendocrine tumors. Many markers are there which are positive and which are negative in the ovarian tumor. Now now basically you should have a thorough understanding on the all cancers, that what is the uh, uh, how it spreads, and what are the characteristic, what are the symptoms, and how it is treated. So this is a very important, because this type of question comes in one way or other, and it is always shuffled. The question is shuffled, and question is asked in one way or other. Same question asked in for example in UPSC, and the same question is asked for in the PGT in a different way, and the same question asked in the PGT, same question will be asked in the postdoctoral examination in a separate way. The question will be same, and it will be twisted little. So you should have a thorough understanding of the ovarian tumor. Now ovarian cancers tend to epithelial ovarian. Now if you are coming to the epithelial tumor first, because there are two types of. Firstly, when we algorithm it, so there is epithelial tumor and non-epithelial ovarian tumor. And in the case of epithelial ovarian tumor, they are classified on the histology like mucinous. Then the cell type is intestinal and endocervical. Serous, it is endosalpingeal. Endometrioid is endometrial. Brenner is a transitional. Clear cell is a Mullerian. Mixed is always mixed. Undifferentiated is anaplastic and unclassified. So they are epithelial tumor. Now we will be coming to the non-epithelial tumor, and all the tumors which we will be discussing subsequently. Particularly, I will be focusing now on the only on the germ cell tumor. So here it will be only discussed it is only of non-epithelial category. Now ovarian cancers actually they tend to present as very late, and they comes with very vague symptoms to you, and the patient which presents in our OPD, particularly when they presents in our medicine OPD, then we refer it to the obstetrics and gynecology department OPD. So first they present in the medicine OPD or there as a very vague symptoms, and firstly they are presents very late, and now actually there is a writer, that's Chavan et al. He accessed that adnexal mass in the postmenopausal women, and most the adnexal masses are the most common clinical finding. With women with the most common finding was a serous cyst adenoma, it was actually, and 30% of the adrenal masses were usually malignant, and out of the cancer affecting the females, ovarian cancer is the most common cause of the mortality. So we must remember that the adnexal masses, and it was known to be as malignant. Now I am discussing in short very all tumor, then I will be focusing on the germ cell tumor. So now what are the general cause of the cancers? They are like nulliparity, increasing age. Now early menarche is also a risk factor, late menopause, family history is also very, very important. BRCA mutation, BRCA1 and BRCA2 mutation. BRCA more common is BRCA1 mutation. BRCA1 mutation causes various type of tumors, out of which the germ cell tumor is also one of them. Now Lynch syndrome, like HNPCC, hereditary non-polyposis ovarian tumor, colorectal cancer, pelvic inflammatory disease also increases the risk of the tumor, and followed by the infertility, white race, postmenopausal hormone replacement therapy, and the ethnic group like European, Jewish, Icelandic, Hungarian, etc. So as per epidemiological point of view, they actually have the high propensity to develop the cancer. Now tubal ligation, hysterectomy. Now tubal ligation and hysterectomy actually decrease the risk of ovarian cancer, and women detected with the epithelial ovarian cancer should undergo the genetic testing. Now epithelial, they are talking of epithelial, I am talking of the epithelial ovarian cancer should go for detailed history and detailed examination, and genetic testing for BRCA1 and BRCA2, because as per the guideline from the Society of the Gynecological point of view. Now what are the clinical features? Now epithelial ovarian cancers present with the because it only tends give to non-epithelial, and it presents with the vague symptoms. As I already told you, the ovarian tumor which presents firstly it presents it very late, and secondly it presents with a very vague symptoms as portrayed like as a silent killer. So women with the non-specific symptoms becomes challenging and attribute them to diagnosis of ovarian cancer, and patients presents with the increased abdominal size will be very high, and pelvic pain, bloating, usually urgency, and there may be also complaint of fatigue, indigestion, decreased appetite, and change in the bowel habits also. These are some of the symptoms which may mimic, and these may symptoms which are the patient always frequently goes from medicine to gynecology, gynecology to medicine, medicine to gynecology, like vice versa. So, and patients occasionally presents with the nausea, vomiting, and rarely with the partial bowel obstruction at the later stage of the disease. Now, on examination, patient present with the may present with like abdominal or abdominal pelvic mass, and conducting by manual examination. And malignant tumors are solid, and they have nodule and have restricted mobility and tend to be fixed. And retrovaginal examination should also be conducted on the ascertain involvement and palpable abdominal or pelvic mass with presence of ascites. Then small point towards the diagnosis of ovarian cancer. Examination should be due to the check of involvement of the peripheral lymph involvement also. So we should also be ensured that whether the tumor has not spread and tumors has not been metastasized to the regional lymph nodes. Now investigation, when we come to the investigation point of view, there is only one solid investigation which we do as a medical oncologist, that is the CA125 before referring to the gynecology oncology department. CA125 tumor marker, which is an integral management of the epithelial ovarian cancer. It is raised in many human condition as well. owing to the non-specific, because it is a very non-specific. CA125 is a very non-specific. It can increase in any other than ovarian tumor or germ cell or any other, because I am concerned with the germ cell only. Because other than this tumor, it can be increased in any of the pathologies or any of the UTIs, or in example like pelvic inflammatory disease or any type of inflammation there in the vagina, or any type of vaginosis, or any type of trichomonas or monilal, etc. It can be increased. The CA125 should be increased, but the main fact is that the clinicians should be individualized and should be appreciated that the CA125 which I am ordering is in the right sequence or not. So CA125 tumor marker, which is an integral and management, and it is a non-specific. However, at least 90% of the cases of the non-mucinous ovarian cancers show elevated levels of CA125, and on the other hand, stage 1 disease will not have elevated value, and CA125 level more than 200 international unit has 90% positive predictive value for the ovarian cancer. So if you detect it, then there will be a high chance that the patient who has consulted you is suffering from some types of pathology of the ovarian tumor. Now the human epidermid protein, that is HE4, used in conjunction with CA125 is a risk of ovarian malignancy algorithm, and which is known as the ROMA. And ROMA is calculated by considering the menopausal status of the woman along with the blood levels of the CA125 and HE4. So HE4 and CA125, if you both do, you can get a rough idea, you can get a bit solid idea than doing alone of CA125. And BMI is also a risk of malignancy index calculated by multiplying CA125 levels, menopausing state, by the USG score, and RM1 and RM2 has been validated. Now here there is a small equation that the RMI is a product of ultrasound scan score and the menopausal status of the serum CA125, that RMI is equal to U into M into CA125. So U for ultrasound score of 1, or 1 for ultrasound of and 3 is for ultrasound. I think it is not going into so much details, just because it is just a rough idea. ROMA is just a score which will give you the extent, and which will give you the extent to which the ovarian cancer has been found. Now I am not going in that detail. Now cancer antigen, this is 19 by 9 or CEA can also be elevated. This is also one of the tumor marker which we do and which we see that it is elevated. And apart from that, on complete blood count there could be thrombocytosis, because thrombocoagulopathy and thrombocytosis is one of the most important characteristic of any tumor, and particularly in the ovarian tumors. And owing to the number of cytokines and the management, now also there will be abnormality in increased retention of antidiuretic hormone. Antidiuretic hormone will be increased, and there will be hyponatremia. There the patient will be suffering from the hyponatremia status. And now if you go for naturally we will perform ultrasonography, and it remains one of the best indicators and modalities to assess the abdominal mass. And the International Ovarian Tumor Analysis Group has put forth now generally IOTA for like it rules unicolor cyst, that irregular solid tumors. So there are B rules and M rules, etc. And for the presence of solid components, where the large solid component is less than 7 cm, it is ascites, and presence of acoustic syndrome has at least 4 papillary structures and no blood flow. So very in B rule, and in M rule it is a very strong blood flow. So these are the ultrasonography features which they have given. And now coming to the I am just coming to the histological types of the ovarian epithelial tumor, and I am just going to the because in the epithelial tumor, germ cell tumors are not there, because as we already know. So I am excluding I am not talking this part. I am directly coming to the ovarian tumor. Now I am coming directly to the ovarian tumor. Now germ cell tumors actually they are derived actually from the primordial germ cell of the ovary, and they account for 50 to 20% of all ovarian tumors. Now many cystic teratomas, also known as dermoid cyst, and is the most common cause of the germ cell tumor, and germ cell tumor constitute 2 to 3% of malignant ovarian tumor. So you should know this very importantly. It is, you should know. And in contrast to epithelial ovarian cancer, germ cell tumor are seen, basically it is a very very important tumor to know, and it is also seen in the girls aged less than 25, and they usually present with the earlier stage with chemosensitive and thus have a good prognosis. Now germ cell tumor generally dysgerminoma, it presents with a good prognosis, and apart from the other pathologies of the tumor which I am not discussing right now, from that this tumor has more or less good prognosis. Now the study, they have conducted a study conducted by the Cherai et al. Conducted a 69 hydrosolar gun with presented with the clinical and radiological evidence of the adenoid mass, and they have concluded that the adenoid mass are frequently found in the abdominals, with most being manageable through observation. While assessing the adolescent with the adenoid mass, the important include new menstrual history and conditional diagnosis of the activity. Among the benign lesion, a simple cyst is the most common encountered type. In children, adolescent, germ cell are the primordial form of ovarian malignancy, and the management of the adenoid masses in this age group, solid focus to preserving the ovaries to maintain the fertility. Now just I will be classifying quickly, because these are the classification of the general germ cell tumor, and as per the WHO, as per the World Health Organization, the classification is very important, which is known as the dysgerminoma, yolk sac tumor, embryonal carcinoma. Then in case of the non-gestational choriocarcinoma, which is mucinous, mature teratoma like solid or cystic, immature, then mixed germ cell tumor, then monodermal teratoma, highly specialized type of arising from the mature cystic teratoma. They are the thyroid tumor, stromal overall benign or malignant, carcinoid, neuroendocrine tumor, squamous cell carcinoma or adenocarcinoma, and sebaceous tumor. Now if you do just a plain algorithm, if you make a problem, the first is the primordial germ cell tumor. They are divided into two types, germinoma and embryonal cell carcinoma. So if you diagnose a germinoma, there will be the AFP will be negative, and we also do to check that which type of histological tumor it is. So in the case of germ cell tumor, if it is a dysgerminoma, AFP will be negative and HCG will be also negative. But in the case of embryonal carcinoma, the AFP will be positive followed by the HCG. And then in the embryonal carcinoma, we come to the extra-embryological differentiation and embryogenic differentiation. In extra-embryogenic differentiation, there is a trophoblast, which is also known as the gestational trophoblastic tumor. So it comes to a choriocarcinoma where AFP is negative again and HCG is positive. And in the case of the yolk sac tumor, this is very important. In the yolk sac tumor, the endometrial sinus tumor where AFP is positive and HCG is negative. Now in the case of immature teratoma, AFP is again negative and HCG is negative, and in the case of mixed teratoma, AFP is negative, where case of HCG is also negative. Now these are some of the algorithm where you must know that where HCG is positive, where HCG is negative. So these questions are also important. These questions are asked always, that in which tumor and which things is this coming. Now the clinical presentation of the germ cell tumor. Now I will want to discuss a brief the subacute abdominal pain. Now subacute abdominal pain is seen about 85% of the singly rapid growth or subcapsular distension, hemorrhage or necrosis. Now 10% of the patient will present with acute abdomen due to torsion, rupture of the cyst and intraperitoneal hemorrhage, and abdominal distension may be seen in the patient with the ascites, and 25% patient present with asymptomatic pelvic mass, and that is usually incidental finding. Now abdominal mass is incidental finding here. Now germ cell tumor secrete hormones, and some cases might present with the signs of excess hormone secretion like the precursor puberty, hirsutism, change in the menstrual pattern, and it may be very familiar with the surgeons or the physician diagnosing as a PCOS, etc. But we should be individualized and we should appreciate by doing the battery of tests, and then we can know that which type of tumor it is. Now, serum tumor marker, like as I told you, that HCG like human chorionic gonadotropin and alpha fetoprotein, its complete blood count and the renal function test are very important. And young girls with the primary amenorrhea and germ cell with primary amenorrhea germ cell tumor must get karyotyping done. So we have to do the karyotyping, because if the young ladies they develop amenorrhea, then there is a chance of that they are suffering from the germ cell tumor. Now, ultrasonography is a sensitive, because USG is a very sensitive specific modality. So and it helps in differentiating between benign and malignant tumor. Doppler sonography is also useful and gives the added benefit of adding the blood flow which is prominent to the tumors. Additionally, MRI or CT may be done if it is warranted to know the staging and other thing. Now, dysgerminoma. Now I am coming to particular germ cell tumor of the ovary, which is dysgerminoma. Dysgerminoma accounts for about 1/3 of all malignant ovarian tumor. Now, this you must know that about 1/3 malignant tumor is just dysgerminoma. They are the most common malignancy detected during pregnancy. Now, in the case of pregnancy, they are most commonly detected, and 5% of them are in the Turner syndrome or Sayre syndrome, and this patient may have gonadoblastomas which may turn malignancy into dysgerminoma, and this can be found in the extragonadal sinus like midline structures from the pineal gland to the mediastinum or to the retroperitoneal glands. Now, 15 to 20% of dysgerminoma may be bilateral. 5% women have raised HCG. Now, this is also very important tumor marker here. So, raised HCG values which can to secretions which have been synthesis of trophoblast, placental alkaline, there is PAP, the placental alkaline phosphatase, and lactate LDH are also raised about 95% of the cases of the dysgerminomas. So, apart from discussing of dysgerminoma, I may just quickly I will come to the clinical features. And as mentioned above, the clinical features are as already I told you before also, subacute abdominal pain, and they can be of varied size ranging from 5 to 15 centimeter with baseline capsule, and the cut surface is fleshy and pale to grayish brown in color, because if you see the gross, when we do the gross, then it is the structure of the dysgerminoma will be like that. And on histology, they are made up of large round or oval polyclonal cells with a pale clear cytoplasm with irregular nuclei and prominent nucleoli, and they might show abundant mitotic figures and associated with the cells with arranged nest separated by the fibrous septae. And syncytial trophoblast generally seen in the associated with like virilization or precursor puberty, and dysgerminoma may coexist with the immature teratomas also, and endodermal sinus tumors or choriocarcinoma, because it may mimic it may coexist, because dysgerminoma, when we see histology, it is a separate, and choriocarcinoma, which is GST, gestational trophoblastic GTP, they are separate, but they may coexist. Now, the very important thing which I am going to discuss right now is the management. Now, surgical treatment is the mainstay of management of the dysgerminoma, and reaction of the primary tumor is followed through staging is very crucial, that you must know, and dysgerminoma is commonly seen in the young girls, and it is necessary to give impulse to the fertility preserving surgery. So we should individualize, and we should we should appreciate that fertility preserving surgeries are done. Now, unilateral oophorectomy is the most common surgical procedure that is done in the involvement of the contralateral ovary. Further spread of the detection, keeping them in the in situ fertility may be taken, as the tumor are chemosensitive, whereas fertility preservation is not needed. A total abdominal hysterectomy with bilateral salpingoophorectomy, that is TSH or BSO, may be done, and is in case of Y chromosome on karyotyping, bilateral gonadectomy is warranted. Now, if we follow a flow chart, like in dysgerminoma, when it is confined to the ovary, So we can do unilateral oophorectomy and examine the contralateral ovary, and then we have to do the surgical staging, and if there is no metastatic present, then we can go for observation or clinical examination every 2 months for 12 months CT scan, and 6 months and then 12 months. Now, for example, if we do in the disseminum only, if you get like suppose occult metastasis, then we give a BEP regimen, that is bleomycin, etoposide and paclitaxel chemotherapy for 4 cycles, and like if there is a small focus of the contralateral ovary, then we reassess the with ovarian presentation, and then we again give BEP of 4 cycles. Now, if for example there is a metastatic disease, because if there is a dysgerminoma and it presents with the mets, so then unilateral sulfoperotomy and remove early this is reachable metastasis, and then again we have to give for the BEP 4 to 5 cycles. So this is the main management, and many patients with the dysgerminoma have a tumor that apparently confined to the one ovary, and will be referred to as unilateral sulfoperotomy without surgical staging. And when we present with a simple ovary, then we do a sulfoperotomy too, because without surgical staging we don't do a surgical. The recommended options depend upon the pathological findings and the managing the similar tumor markers, like we can do like beta HCG or LDH to know the status and the age of patient, whether he desires fertility preservatives, and the options include complete surgical staging, complete surgical staging as stage 1 dysseminoma, or whether we will individualize whether the chemotherapy will be needed or not, and clear surveillance with the periodic abdominal CT tumor markers, and adjuvant chemotherapy if capsular rupture and or if it is an advanced age. Now, radiotherapy, because dysseminoma are very radiosensitive also, so we can give a dose of 2500 to 3500 centigrade, and it can be used for treating metastatic disease. Owing to due to the loss of fertility due to radiation, this modality is seldom used as a primary treatment nowadays. So we should also consider, and we should also see, and in the CT or the chemotherapy based, and platinum based chemotherapy is deemed to be treatment of choice as a added benefit of being less toxic to the patient and the preserving fertility. And given and in the giving statement which I am going to give, I will be telling about the intravenous chemotherapy drugs which are used in the BP regimen. Bleomycin, as I told you, that is 30,000 intravenous unit on the day 5, 8, 11 and 15 in 3 weeks. Then etoposide 100 mg per body surface area for the 5 days every 1 week, and cisplatin is 20 mg per body surface area to 5 days, or 100 mg per body surface area for 1 day, continuing to 3 weeks. Then we can come to this is the VP regimen, and then we also can give to the VBP regimen, that is vinblastine. Vinblastine we can give at 0.15 mg per kg day in day 1 in 1 or 2 every 3 weeks. Bleomycin also 15 mg per units per week into 5, and then day 1 course 4. And cisplatin is 100 mg per body surface area on 1 day every 3 weeks, on any particular 1 day in 3 weeks. Now there is a VRC combination also, that is vincristine, actinomycin and cyclophosphamide. In vincristine, there we can give at 1 to 1.5 body surface area on day 1 every 4 weeks. Actinomycin D 0.5 mg per day with 5 days every 4 weeks, and cyclophosphamide 150 mg per body surface area into 5 days each 4 weeks. So this terminology and this thing you must remember, and this is very important on the treatment point of view, that how the treatment is given, on what dosage the treatment is given for the germ cell tumor. And so in this way the follow-up is done. And follow-up, all treated certain germ cell tumors are followed by 3 monthly by clinical examination or tumor markers for initial 2 years. So we actually the gynecological oncologist or the medical oncologist here plays a crucial role by doing the serial battery of test of tumor markers and the various markers, and to know the status of the tumor. Now recurrence disease, because recurrence is also seen around 75%. Now it is also known that recurrence is seen 75% patient with 1 year of initial treatment. The most frequent sites of metastasis are within the peritoneal cavity and retroperitoneal lymph nodes. Now patients who have recurrence of the disease and who have not received chemotherapy before, it should be treated with chemotherapy as described, like BP regimen can be previously second line agent with the TIP. TIP is a paclitaxel, ifosfamide and cisplatin, or VIP, vinblastine, ifosfamide or cisplatin can be used. Now there is also another therapy, that is POM-S chemotherapy from germ cell tumor. The sequence of the treatment schedules of the 2 course of the POM follows by the AS, and POM is altered with the AS with the persons with the biochemical remission measured by the SCG and AFP and PLAP and even LDH. The usual number of courses of POMB is there to 5. Following biochemical examination, patients alternate with the S with the OMB remission has been maintained for approximately 12 weeks. Now the interval between the treatment is kept up to the minimum like 9 to 11 days, and if delays cause myelosuppression and other cause of the courses of ACE, the first 2 days of etoposide are committed from the subsequent courses of the ACE. Now in the case of the POM, in the day 1 you have to give vincristine and methotrexate 1 mg per body surface area, then methotrexate 300 mg per body surface area as a 12-hour infusion. Then step 2 is the bleomycin only, 15 mg per as a 24-hour infusion, and then rescue, then the reuse started from the 24 of the methotrexate and 15 mg per every 12 hours for 4 doses. Now in the case of the day 3, bleomycin again infusion 15 mg as a 24-hour infusion, followed by the cisplatin in day 4, 120 mg per body surface area into 12-hour mutation given over the hydration, and 3 gram magnesium sulfate supplementation. So these are the some of the combination of the germ cell tumor that in which regime you want to give. And in the case of, if you go for the ACE type like etoposide, actinomycin or cyclophosphamide, there you can give days 1 to 5 etoposide, which is a combination of vincristine and paclitaxel with etoposide. It is 16 to 213, like 100 mg per body surface area, day 1 to 5. And in days 3 to 5, actinomycin 0.05 mg per mg IV in days 3, 4 and 5, and then cyclophosphamide 500 mg per square in day 5. And if you want to give the OBM is that is bleomycin, vincristine and bleomycin again. Vincristine 1 mg with methotrexate 300 per mg square with 12-hour infusion. Then in day 2 we can give bleomycin 15 mg as a 24-hour infusion acid rescue, and 24-hour start of the methotrexate dose of 15 mg for 12 hours, or bleomycin 15 mg as a 24-hour infusions. So these are the various dosage which you must know, and which type of dose and which type of chemotherapy group will be given to you, that you have to individualize depending upon the battery of tests, as I told you. So in this way we have to appreciate and we have to decide. Now if there is a pregnancy with dysseminoma, as I told you, since dysseminoma always appear in younger in the patient, they can occur along with the pregnancy. And if stage 1A tumor is discovered, like for example if you see the FIGO stage, if there is a stage 1, it can be removed without affecting the pregnancy. For the patient with more advanced stage of the disease, whether pregnancy can continue to dependent on the fetus gestational age. So it will be depending upon the fetus gestational age. So, and chemotherapy can be administered safely during the second and third trimester, and using the same dosage for the non-pregnant without any bad affecting to the fetus. So, a study conducted by the Chavan et al., including 44 cases of pregnant women and adrenal cell mass, out of them 3.32% were dysseminoma and 24% women were teratomas. So, for the patient with the stage 1A disease, which is characteristic by unilateral encapsulated germinoma, performing the unilateral oophorectomy leads to the 5-year survival of above 95% and is a very good prognosis. And factors associated with a higher likelihood of the recurrence include tumor size larger than 11 to 15 centimeter diameter, presents with a younger than 20 years old. It may develop a microscopical picture that show numerous mitosis, anaplasia, and medullary patients. So this is the only discussion about the germ cell tumor of the ovary, and especially I have talked about the dysgerminoma, how to manage the dysgerminoma and how to stage the dysgerminoma, and what are the you must know the FIGO staging. So FIGO staging is also very important to know the that where we are staged, and there the staging is very important. And so these are some of the treatment options which are required for managing the germ cell tumor of the ovary, particularly dysgerminoma. And in the next video, I will be discussing about the other tumors of the ovary also, which will be equivalent to, as I said, to all. And then I will be discussing about the sarcoidosis also, because this is also a very important topic that I will discuss in the next, because the video is very large now. So I am stopping here, and if you have any difficulty and if you have any doubt, you can always post in my group, and there I can explain you everything if you want to know in detail. Because the question, because this chapter is very important, and this chapter always comes in the following exams, which I already told you. So you should have a clear-cut understanding about the treatment, about the staging, about the symptoms, about the pathophysiology, about everything. So this is the thing, and then in the subsequent chapter I will be starting with the rest of the ovarian tumors with then I will be shifting to the medicine part, which will be also useful for the in discussing with the sarcoidosis, which will be useful for, as I told you, for everybody. It will be useful for the UPSC also, it will be useful for the NEET PG, as well as for the NEET postdoctoral, and for the useful for the PGTs of the medicine department also. Thanks a lot.